as we get the next slide prepared, the next speaker will be Mrs. Temima Wildman-Lebowicz, who actually serves a very, very important role in Memorial Sloan Kettering. Unfortunately, we know that cancer plays a very big role in sickness in every community, but it's certainly, unfortunately, not far into the Jewish community. And when certain cancers can be avoided, when certain sicknesses can be avoided and can be dealt with properly, it's a tremendous benefit to the community. And as I said in the beginning, in my address, that we have a jam-packed program, and I don't want to take up any more time. So really, without further ado, Mrs. Temima Wildman-Lebowicz.
This is forward, this is the point. Okay. This is forward, and the middle is the point. Okay.
All right. Hi, can you hear me okay? Okay. Thank you, everyone, for coming, and thank you for inviting me to speak here today. So as Rabbi Segelman mentioned, I'm a genetic counselor at Memorial Sloan Kettering, and I see a lot of people from the Jewish community who come in, and there's a few reasons for that. So the topic that I'm addressing, as Dr. Kearns had kind of talked about for a few minutes, but we'll spend some time speaking further, is about hereditary cancer. And this is a topic that's a little bit different from what the other speakers will be talking about, but a very important topic to speak about today. So in the short time that we have today, I want to define what is hereditary cancer and talk about what the unique risks are in the Jewish community. We'll talk a little bit about opportunities for prevention and early detection. There are different options that people have to manage and decrease the risks that they have. We'll talk about the pros and cons of genetic testing. And to sum it all up, we'll talk about why genetic testing matters and why this is important to talk about. So, fact or fiction, and I've stolen this from Dr. Offit, who is the head of genetics at Sloan Kettering. This is something he likes to do. So most cancers are hereditary. Do you think that is true or false? False. Correct. That is fiction. So most cancers are not hereditary. About 75% of the time, cancer is what we call sporadic or happens randomly by chance due to bad luck or aging. We know that cancer risks get higher as someone gets older. Environmental factors, about 15 to 20% of the time, it is something that we see running in the family. We call that familial cancer. And only about 5 to 10% of all cancers are what we call hereditary or caused by a mutation in a gene. So Dr. Kearns went over a little bit about genes. Our genes are made up of a code of letters. It has a specific spelling to them. And our genes code for proteins, which do the actual work in our bodies. When there's a mutation or a change in the spelling of a gene, that can cause a protein to be damaged and either not to be formed or not to be formed properly, and then it can't do its job. When we're thinking about hereditary cancer, where there's a mutation in a family that's causing the cancer, we see that multiple generations in a family are affected with cancer. So we can see a grandparent, a parent, and then another individual, or aunts and uncles affected. We can see multiple cancers in the same individual. So for example, a woman who has bilateral breast cancer or breast and ovarian cancer, that is something that we would be concerned about when we're thinking about a hereditary risk. Diagnoses at earlier ages. So generally our cutoff is age 50. So anything diagnosed under age 50 is a concern for a hereditary cause for that person's cancer. Rare cancers such as male breast cancer or ovarian cancer, any diagnosis of that warrants a genetics workup. There are certain types of pathology that we see in tumors. So that's like the specific type of breast cancer, for example, that can be more closely linked to a genetic predisposition. And finally, what we would be focusing on today is Ashkenazi Jewish ancestry. So as Dr. Kearns mentioned, BRCA mutations, for example, are more common in Ashkenazi Jews. So that's what we would be focusing on today a little bit, is the hereditary cancer in the Jewish community. So is cancer more common cancer in general more common in the Jewish population? Fact or fiction? Fact. Fiction? So it's fiction. That cancer is not more common in the Jewish population. But what is more common is the hereditary version of cancer. And so what that means is that a higher proportion of cancers in the Jewish population are due to a genetic cause than people who are not Jewish or not Ashkenazi, to be more correct. And the reason for this is because something called the founder effect. So, and this is kind of an explanation of why in general there are more mutations known about in the Jewish population. Because if you have a population, and this orange is depicting a mutation, you have one individual out of, let's say, 15 or 20 here, and then, as we know throughout Jewish history, there's been different things where people migrated, or there were pogroms and people were killed, and so the population decreases. So now you have 1 in 5 that carries this mutation. And then that population reproduces, and generations later, this mutation has become a lot more prevalent. So that's called the founder effect. So now to focus a little bit more about BRCA1 and BRCA2, I'm sure many people in this room have heard about these two genes. These two genes, they're associated with a syndrome called hereditary breast and ovarian cancer syndrome, or HBOC, you may see it abbreviated. But the name is a little bit of a misnomer because we know that these genes can also increase risks for some other types of cancer, and we can see cancers in men as well and not just in women. So BRCA1 and 2, Ashkenazi Jewish founder mutations. So the 3, I mentioned founder mutations before, there are 3 specific changes in these genes. These 2 are in BRCA1 and one of them in BRCA2. BRCA1 and BRCA2 are 2 different genes, but they work very similarly and cause similar cancers, and we pretty much treat them the same with the same management that I'll go through. But the risks do differ slightly. These mutations are relatively common. So you can see in the general, in Ashkenazi Jews, you can see how common this is, but altogether, they make up about 2.5% of the population carries one of these 3 changes that can increase the risk. So that number, 2.5%, is 1 in 40, which is considered very high in the genetics field. And it's about 10 times more common than it is in the general population of people who are not Jewish. And to add to that, we've seen that this 1 in 40 number is just as common in people who have a family history of BRCA-related cancers and those who do not have any family history. There have been studies done in Israel where the carrier frequency is the same, regardless of family history. So right now it's not accepted to test everybody in the Ashkenazi Jewish population, but that may be something coming on the horizon, and there are studies that are trying to see if that is something that can be done. So I kind of gave you the answer to this already. We'll see who's listening. Fact or fiction, BRCA1 and BRCA2 mutations only affect women. Fiction. And BRCA1 and BRCA2 mutations are only maternally inherited, meaning they can only be inherited from the mother and not from the father. Fact or fiction? Fiction, that is correct. So both men and women are at increased risk for certain cancers, but the cancer risks differ by gender because men don't have a lot of breast tissue and they don't have ovaries, so women are more likely to be affected. And both men and women can inherit and pass down BRCA mutations. So this is a dominant condition, but having a mutation isn't a diagnosis of cancer, it's a predisposition for cancer. But because it is dominant and not on the sex chromosomes, it is a 50% chance for a person who carries a mutation to pass it down with each pregnancy, regardless of the gender of the individual or the gender of the child. So BRCA, we mentioned that there's increased risks for cancer. So specifically, the blue here is representing a BRCA carrier, and I'm not differentiating between BRCA1 and BRCA2 here. And the second column here is the general population. So you can see every woman has a risk for breast cancer, about 12.5%, but someone who has a BRCA mutation, their risk can be up to 80% over their lifetime. That's by age 70. And a woman who has a breast cancer diagnosis also has an increased risk to get a second breast cancer or a breast cancer in the opposite breast. And finally, so for the ovaries, it's a very rare cancer, like I mentioned. Only about 1 to 2% of women will develop ovarian cancer in the general population, but you can see how high that risk is in the setting of a BRCA mutation. Male breast cancer, again, is very, very rare. About 0.1% of men develop breast cancer, and still on the lower side, but it is significantly higher than someone who does not carry a BRCA mutation. Prostate cancer, again, is a relatively rare cancer, relatively common cancer in the general population, but it is increased in men with BRCA mutations, and they tend to be more aggressive types of prostate cancer that would require treatment. There are many men who have prostate cancer, don't need treatment for it, just kind of watch it, but in the setting of a BRCA mutation, those cancers can be a little bit more aggressive. We can also see increased risk for pancreatic cancer and possibly melanoma as well. So in terms of prevention and early detection, there are a few different things that people can do. So there's kind of two different things to think about when we are trying to manage this risk. One is screening, so trying to catch cancers at an earlier stage where they're more treatable, and then there's prevention to just prevent the person from developing cancer in the first place. So for the breast, we do increased screening. Most women in the general population start with mammograms only at age 40. We start much earlier at age 25 for women with BRCA mutations with a more intensive screening with a breast MRI, and then we add in mammograms a little bit later on. And then there's also the option for women to have a risk-reducing mastectomy to remove the breast before there's any cancer diagnosis. For the ovaries, though, we don't have any effective screening. Some doctors will do a blood test and ultrasounds, but they're not effective. There have been studies done. The FDA came out against ovarian cancer screening because it is not seen to be helpful. And because of that, we do recommend that women have a risk-reducing salpingo-oophorectomy, which is the removal of both ovaries and the fallopian tubes by age 40. For men, we start prostate cancer screening slightly younger with a blood test and a physical exam. And we tell men to feel the breast tissue if they have a BRCA mutations, and some men will do mammograms, although that is not a consensus recommendation. In terms of pancreas cancer, there is no effective screening. There are research studies, and many institutions in New York City and other major hospitals have research studies to do investigational MRIs or ultrasounds. We have that at MSK, where we refer our patients who have a family history and a mutation. And for melanoma, we tell people to do annual dermatological exams. So this isn't something that's relevant specifically to the Jewish population, but it is important for people to know. So BRCA1 and 2 are considered high-risk genes, where the risk for breast cancer is considered very high as compared to the general population. But there are a number of other genes, and these are just examples, that are genes we call moderate risk genes, where they can increase risk of breast cancer and can explain a family or personal history, but the risks are not as high. And so the management for those genes is a little bit different. These are genes that we've only been testing for about 6 to 7 years now. So they're newer genes that we're still learning about, but we have seen that it does increase risk for breast cancer and some other cancers as well, and they're important for people to know about. If there is a very strong family history, then not only should BRCA be tested, but also these other genes. And there is a specific founder mutation in the CHEK2 gene as well. So many people have had BRCA testing in the past, but if it wasn't done within the last 7 or so years, and even 7 years ago, they may not have been tested for all of these genes that are clinically relevant at this time. So fact or fiction, if genetic testing is negative, meaning someone does not carry a gene mutation, you are not at risk for cancer. Fiction. So there is, sorry, this got a little messed up here. So negative results can sometimes be falsely reassuring, and that's why genetic testing is really important to do in the setting of genetic counseling, because even if someone has a family history and tests negative, they may still be at increased risk for cancer based on their family history alone. And there's also the population risk. Everybody has risks for cancer, regardless of family history, and people still need to be doing their annual screenings that is recommended for the general population. Another limitation of genetic testing is sometimes we can get uncertain results. These are called variants of uncertain significance, which is basically a question mark. We just don't know what these particular changes mean, and there still need to be recommendations and follow-up done. But benefits of genetic testing, aside from the risk management that we talked about, where we would do increased screening, preventative surgeries, and sometimes medication, depending on the genetic mutation, whether it's BRCA or some other conditions that can increase risk for different types of cancers. Targeted therapies, so in certain genetic conditions, so in BRCA, there are certain drugs that can be used, certain types of chemotherapies that can be used that are targeted to the BRCA mutation. For example, in people with pancreatic cancer, this has been extremely effective, and people do really well on these types of medications that have been proven to be helpful in the setting of a BRCA mutation. The other thing is to define risk for family members. So let's say a parent has a BRCA mutation, has had cancer, and their child does not have that mutation. Well, we know that that child is not at increased risk and does not need to have these additional screenings. And that's really important to understand what people's risk really is. So a true negative is when we have a mutation in the family that explains why there's cancer, and this person has tested negative for that mutation. And as Dr. Kearns kind of talked a little bit about, IVF with PGD, where if there is a mutation in a family, people can do something to prevent passing this on to future generations. And in the setting of BRCA2, for example, this is especially relevant because we know that when two parents are both BRCA2 carriers and they both pass that mutation down to their child, that's a 1 in 4 chance. Then it's a risk for a recessive condition called Fanconi anemia, which is a very serious childhood onset condition. And there's a number of different genes that can predispose to Fanconi anemia. Some of the other genes can predispose to other genetic conditions, just such as ATM, can predispose to a syndrome called ataxia-telangiectasia. So it's really important to understand what the risks are for children and offspring and to prevent those diseases from occurring. So I'm just briefly going to talk about a case example. I didn't want to put in all the pedigrees, but I had a patient who was about 32 years old. She had a 1-year-old son, and there was a known BRCA2 founder mutation in her family. So she had actually already had testing, and she came in to talk about those results. And in taking her family history, she told me that her husband's father, who had a history of prostate cancer, had just been diagnosed with pancreas cancer at age 64. Her husband's grandmother had just been diagnosed with her second breast cancer at age 90. And I think there was an aunt with a cousin with breast cancer at age 40. And I said, well, they're Ashkenazi Jewish. They should definitely have genetic testing. And so I think what happened was her husband enrolled in a research study that we have to test anybody of Ashkenazi Jewish ancestry for these 3 mutations. And he came back with a BRCA2 mutation as well, the same founder mutation. And then there was more testing that went on, and they did find that mutation was present in his father. And so then he had treatment options for his pancreatic cancer because we can use these PARP inhibitors to treat that. And so that was like a very relevant thing that happened recently where we are using these results very effectively to treat people and to make sure that that's really life-saving. So in that setting where someone has a cancer diagnosis, it was really, really relevant. And then the couple was concerned about their son, who was 1 year old and very healthy, but they were concerned about the risk of Fanconi anemia since that's something we had talked about. He was fine. Actually, we realized that when it's the same mutation in both families, that actually won't result in Fanconi anemia because you need to have some working BRCA2 protein. So that wasn't a concern. We tested him anyways to make sure he was fine, but that was something that was really relevant and really important in kind of a few different ways in terms of cancer risk prevention and also in terms of children. So at this point, I thank you. Thank you for listening, and I will be around if there's any questions.
Okay, thank you very much. That's such an important talk. You know, when people give blessings to oncologists and the bracha is that you shouldn't have any patients, you shouldn't have any parnasa. That's like the bracha we give. Really what they're saying is that everyone should go seek out genetic testing before so we could prevent all of the terrible cancerous options. But really, tremendous work that you do. Shir koach.